much, Katie. Let me see if I can get this screen shared here. First of all, I just wanted to say hi to everybody. It's really great to be here. It's an honor. I'm really excited. I just, first of all, want to thank Helen and Katie and everybody who organized our education day today, as well as our sponsors, as well as you all. And many of you all have walked for Miles for Migraine in the past and helped us raise money at UT Southwestern to support our fellowship program and help train more headache specialists, which we are in dire need of. So what you're doing out there it's super important and it's really appreciated, and I'm really happy to be with you today. So let me see if I can make this work.
Well, thank you for saying that.
You're welcome. You see anything yet?
Yes.
You see my emails? No. Okay. Do you see the whole screen?
Oh, we see the whole screen.
Yeah?
Yeah.
Let's go back to the beginning and see the whole screen.
Yep, we're getting there.
All right, let's go.
Now.
First of all, thank you, Jaya. It's really great to see you. You know, we've all been doing our thing on telemedicine, so I appreciated getting stretched out during your talk today. And, you know, we haven't seen each other in a while because I haven't been in the hospital, so thanks for your contribution.
Thank you, Dr. Friedman.
You're welcome. I miss you. I have a great team here. So you've heard about Dr. Bay and you've seen Jaya, and we have Dr. Mesroor, who is a facial pain specialist, and Dr. Karashi, and wonderful nurse practitioners and physician assistants. And we really enjoy what we do and we're passionate about it. I do consult for many industry partners, and some of them have sponsored the program today. So what's on the menu? It is almost time for lunch over here in Dallas. So what I'd like to talk about is some new and emerging treatments. Do you have the full screen? I just want to make sure. You're not looking at presenter view?
We are looking at presenter view, I believe.
No, we don't want to look at presenter.
Yeah, there's.
It's weird how it shows up.
Go.
How's that better? Okay. You can't like see the secrets before I get to them. So anyway. We're going to talk about what's new, relatively new anyway, and things that have just come out on the market for both the acute and preventive treatment of migraine, and just a little bit about cluster. Compare them to some of the existing treatments and talk about their indications and their limitations. So the detailed menu is we'll discuss the monoclonal antibodies that target calcitonin gene-related peptide, as well as the small molecules that are targeted against that particular peptide. New class of medications that's out, they're called the ditans, and they target very specific serotonin receptors. Things that are in development, including the PACAP38 receptor antagonist, some devices, and some reformulations. So, you know, I think it's kind of a no-brainer, I guess neurologists shouldn't use that term, to say that everybody should be offered acute treatment. It often surprises me how many people are not offered acute treatment that I see. And acute treatment is not just medications. As you're probably well aware, there are a lot of other natural things and homeopathic things that can be done for acute treatment. So just to keep in mind that, I'm aware of this, even though I'm just going to talk about meds and devices today. And, you know, until recently, we didn't have that much. I think this is the wrong slide because it's not coming out right, but that's okay. So we had triptans. Triptans changed the world when they came out in the early 1990s. Before triptans, we had ergotamine and ergotamine tartrate, which if the patient wasn't already vomiting, the medicine would make them vomit. We had over-the-counter combination analgesics, prescription analgesics, meds for nausea, which are so important and often overlooked, non-steroidal anti-inflammatories. Often, you know, when I did my training back in the days when the dinosaurs roamed the earth, what they used to say, well, just, you know, give the patient a bunch of Benadryl and let them go to sleep, because sleep always works. And sleep is important, so sometimes that helps. We had opioids. We certainly try not to use opioids, but now we have the three things on the left side of the slide. So we have the ditans, the anti-CGRP therapies, as well as neuromodulation. I think it's also important to keep in mind with acute therapy that there are two strategies that tend to be used. And it's it's helpful if people can identify which of their headaches might respond to which of these strategies. It may help you get better faster when you have a bad migraine. So the first is step care. And I'll say that the biggest fans of step care are the insurance companies. So step care means that the medications are taken sequentially. Well, I think I feel something coming on. Maybe I'll take a little bit of Tylenol, and it's 45 minutes later and that hasn't worked. And what else do I have lying around in my desk? You know, ibuprofen. Okay, we'll try that. Okay, it's 45 minutes later. This should have worked by now. It hasn't worked. So let's go to the big guns and get out some butalbital, some Furosat, which is, you know, honestly one of our least loved medications as headache medicine providers. We had call it the F word. So we try the F word. Okay, another 30, 45 minutes go by. That didn't work. So now we're going to get that triptan. And unfortunately, once hours have gone by, the triptan's not likely to work. And that's because this process is already revved up in the brain. It's called central sensitization. And we've kind of missed the golden window of opportunity to make the migraine better. So many people find that they're kind of on climbing this ladder and taking medication after medication after medication and not getting good relief. Why do the insurance companies like this? Because all those medicines until you get to number 4 are cheap. Okay, then there's stratified care. Stratified care means that you experiment a little, find what's really going to work, the treatment you know is most likely to work, and start with that treatment. And you're more likely to get relief. So I kind of say go for the gold when it comes to acute treatment. So let's start with the calcitonin gene-related peptide medications. And the intro to this will apply not just to the acute treatments, but also to the monoclonal antibodies that we'll talk about in a few minutes. So calcitonin gene-related peptide is a very potent dilator of blood vessels. It's found throughout the body. And it also plays a role in inflammation within the nervous system. And we know that inflammation is part of the migraine process. It is found throughout the trigeminal system. So it's the system in the brain that controls pain, as well as sensation to the face and the head. And it is released by peripheral nerve endings. So if you look at the picture, there's the trigeminal ganglion, which is actually not inside the brain. This is the trigeminal nucleus, which is in the back part of the brain. And these are the nerves that take the information from various parts of the face into the trigeminal system. Those nerves also supply the lining around the brain, which is called the dura or the meninges, and they supply the blood vessels in the brain. So there are tiny nerves that actually supply the blood vessels. And it's at the level of the dura and those blood vessels where a lot of this inflammation takes place. And calcitonin gene-related peptide is released during a migraine, during a cluster headache, and it helps kind of make that pain continue on. So, it is a peptide, and I know that we kind of talk a different language in medicine. And in case it's been a while since you took chemistry, it's been a while since I took chemistry. What is a peptide? I found it interesting when I looked this up to know that peptide actually comes from the Greek word peptos, which means digested. Who would have thought? And a peptide is a compound that consists between 2 and 50 amino acids. So amino acids are kind of the building blocks. A bunch of amino acids get together, they form a peptide. And a lot of peptides get together and they form proteins. So peptides are the building blocks of proteins. I know you all heard about diet cooking earlier today. And so when you eat proteins, the enzymes kind of reverse this process. So they break down the proteins from peptides and then into amino acids. And some of these amino acids are used to form neurotransmitters. They help the nerves talk to each other, as well as histamine. So what are these medications that are for acute therapy? You're probably familiar with them by their brand names, and they're all advertising all over the place. So they've probably heard about them on TV. One is called Nurtec and one is called Ubrelvy. And they are very similar in that they both target the CGRP molecule. Nurtec is available as an oral disintegrating tablet, and Ubrelvy is available as a regular tablet that comes in 2 different strengths. There is one more that is in clinical trials right now, which is called Vazegepant. As you'll see, some of these are, or their cousins, are also being used as oral therapy. They're being tested for preventive therapy as well as acute therapy. The other one that's brand new is a 5-HT1F receptor antagonist. So 5-HT is basically serotonin. And we've known for many, many years that serotonin plays a part in the development of migraine, as well as some of its migraine's friends, anxiety, depression, things like that, that kind of hang out together with migraine. So the triptans also act on serotonin, and they act on the 1B and 1D receptors. The new medication acts on the 1F receptor. Okay, so you can see the 1D receptor that's here in the nerve cell, the 1B receptor that's located on blood vessels, and that's why triptans can be a problem for patients who have heart disease or Raynaud's phenomenon or other kinds of peripheral vascular disease because of the 1B receptor action. They constrict blood vessels. So there are many people out there that have medical problems such that they cannot take triptans. The 1HT1F receptor has nothing to do with blood vessels. And the CGRP drugs also have nothing really to do with blood vessels. They don't, even though CGRP dilates blood vessels, their antagonists don't constrict blood vessels to any significant extent. So all of these things can be used in people who can't take triptans, which is really nice. The 1F receptors enter the brain, which helps them work, but it also accounts for some of their side effects. And they also block that inflammatory process in the dura. So the one that was just marketed is called Rayvow, and it's indicated for acute migraine treatment in adults. When they looked at the data for Rayvow in the clinical trials, for the 200 milligram dose, which is not marketed for 200 milligrams, 40% approximately of people got pain-free in 2 hours after taking it, compared to about half that many who took the placebo drug. And it also was helpful for the relief of the most bothersome symptom, which for most people is sensitivity to light, but could also be sensitivity to noise or nausea, the way that the FDA defines it. So, you know, all of these drugs that I just mentioned have similar efficacy. They've all been studied against placebo. Now, none of them have significant cardiovascular effects, but for lasmiditan, about 17% of people with lasmiditan got dizzy after they took it. It was generally mild. It went away pretty quickly. But for that reason, the FDA has kind of put on the label that you shouldn't drive within 8 hours of taking lasmiditan. So keep that in mind. We do have guidelines for when we offer preventive treatment. And I'm not going to spend a heck of a lot of time talking about them, other than to say that, again, this group, you know, is probably very familiar with all of these guidelines because they may have affected you. But again, it always surprises me in practice how many people should be on a preventive that are never offered a preventive. And there are very clear guidelines about when they should be offered, and patient preference is high on the list. So keep that one in mind. So again, until recently, there wasn't a heck of a lot out there. We had a lot of medications that had been originally developed for other disorders that were found sort of, you know, by chance that they worked for migraine prevention. And there's nothing wrong with that. A lot of great things have been found by serendipity. My favorite one to talk about it is actually Viagra. So Viagra was developed initially for patients who had pulmonary hypertension. The blood flow to their lungs was, with the blood pressure was too high. And so they developed this drug that increased the blood flow, right? They did the clinical trial. And when they finished the clinical trial, if anybody's ever been in a clinical trial, you know, they ask you to bring back all your unused medication. And amazingly, like, nobody brought back any unused medication, especially the men in the trial. And that was when they found out that actually Viagra had sort of an unintended side effect that turned out to be a total blockbuster for Pfizer. So nobody actually thinks of Viagra as being a pulmonary hypertension drug, which it is, but it's famous for, being an erectile dysfunction drug. So serendipity can be good. But none of these drugs were made to treat migraine, initially, although some are FDA approved. Then came Botox. And Botox was a real game changer for a lot of people when it came out, and it still is, as well as neuromodulation devices. And then the latest one to the game is the anti-CGRP monoclonal antibodies. So, even though a lot of these oral medications are good, we know that it's hard to take them. And the discontinuation rates are huge. And most commonly, people stop taking them either because they don't work, and sometimes it's because they haven't been given an adequate trial, but for whatever reason, they don't work, or they're having side effects. And the problem with having non-targeted treatment is that you get effects and you get side effects because there's a lot of off-target action. And some people got lucky and their headaches resolved, and that's why they came off of them. So, there's definitely need for improvement, and I'm happy to say that within the past couple of years, that has entered the realm of headache medicine. So the monoclonal antibodies block CGRP, but they don't constrict the blood vessels. They were developed specifically to target CGRP or its receptor and nothing else. And even though they're antibodies, they just happen to be monoclonal antibodies, people think about antibodies and they think about their immune system. These do not affect the immune system. They don't target the immune system. So they reduce the amount of CGRP that's available, and they're not eliminated through either the liver or the kidney. So that's also really helpful because oral drugs are pretty much always eliminated through the liver or the kidney. So if you have liver problems or kidney problems, that can be a real limiting factor. So this is a busy table. I'm not going to go through the whole thing. But the four that are currently on the market are Emgality, Vyepti, which is the newest one. It's given intravenously, Aimovig and Ajovy. Other than Vyepti, they're all given by a subcutaneous under the skin injection once a month. The exception to that is Ajovy. Ajovy can be given either every month or you can triple the dose and give it every 3 months. It works just as well regardless of how you want to give it. And then the Vyepti is given every 3 months intravenously, so you need to go to an infusion center and get it infused. They all target the CGRP molecule except for Aimovig. Aimovig targets the receptor, and that may have some bearing as to why certain side effects happen with Aimovig that are not as common as with the other ones. They've all been studied in high-frequency episodic migraine. They've been studied in chronic migraine. They are FDA approved for migraine prevention. So the FDA does not separate out episodic versus chronic. Emgality was also successfully studied for cluster headache. And so it's FDA approved for the treatment of cluster headache in a dose that is higher than the dose that's used to treat migraine. So there are a lot of nice things about these drugs. One is that they can sometimes act very rapidly, particularly the intravenous form. There are people that get improvement with Vyepti in the first day, and their headaches go away. Now, that's not guaranteed, and that's a small number of people. But for many people, the monoclonal antibodies do have a rapid onset of action because they're started at the target dose. So remember, with oral drugs, we have to kind of ramp up the dose. And with monoclonal antibodies, we don't need to do that. We just kind of start at the optimal dose. Now, that said, although a lot of people get relief pretty quickly, I think that there were a lot of unrealistic expectations when these drugs first came out. And so people thought that if they didn't get improvement within the first 2 weeks, that it was never going to work. And so I'm sometimes seeing people that had a 1-month trial or a 2-month trial and it didn't work. And they may have gotten benefit if they'd stuck with it longer. Because for some people, it can take up to 6 months for it to work. And that sounds like a long time, but that's basically 2 cycles of Botox, right? So it's not much different. They all showed superiority in reducing the number of migraine days, the number of headache days. When people came into the studies and they were overusing acute medication, many of them, because they had such good headache control, were able to come off of their acute medications and were no longer overusing acute medications at the end of the trial. The average improvement over placebo, so this is not the absolute number, it's just the gain over the placebo, okay, was about 1 to 2 migraine days a month for episodic migraine, with overall about a 50% improvement, and then about 3 to 4 days a month for chronic migraine, again, overall about a 50% reduction or more in headache days every month. In general, they are well tolerated. It's not to say they don't have side effects. Even if people have tried other medications before and didn't have good luck, many of these people have done very, very well on the monoclonal antibodies. And really, there are no known contraindications, so no circumstances where we absolutely cannot use them, except pregnancy. And it's only because we don't know what happens in pregnancy. So the common side effects that have been reported are injection site pain and redness. Erenumab or Aimovig in particular tends to cause constipation in some people, and it can be very severe constipation. And there's now a warning on the label for Aimovig that it can actually totally clog things up. Other things that happen to a very small percentage of people: upper respiratory tract infections, nausea, hair loss. We've seen a little bit of that. And so far, no cardiovascular signals to date. I'm not going to go into like a million graphs of, you know, what the clinical trial shows, but I just wanted to kind of give you a little sampler of what pretty much all the graphs look like. So this is the Aimovig chronic migraine trial. It was one of the earlier studies. So on day 0, on the baseline day, people got their shots. They either got a placebo injection, they got Aimovig 70 milligrams or Aimovig 140 milligrams. At week 4, you can see the placebo folks, they're down at almost 3 days of headache a month, compared to 5 headache days a month for the active Aimovig treatment. And by the end of the study, people who got the active drug lost almost a week of their headache days, compared to about 4 days for the placebo. But the drop-off occurred pretty quickly. And I think that's might be where the misconception came, that it was going to just work in a month and be done, because people do continue to improve over time. The baseline number of headache days in this group was 18. These are the results from the prior treatment failure people. So these are people that had taken Aimovig but never had prior treatment failure. And you can see in the red and the blue that they got better. People that had at least one medication they took that didn't work for them or they didn't tolerate, and it looks pretty similar. And then people that had tried more than 2 medications in the past that didn't work for them, again, it looks pretty similar, with similar numbers of headache days reduced. So just because you didn't do well on treatments before shouldn't stop you from trying these. So what does a Botox graph look like, right? What are we comparing this to? And this is from the PREEP study. It was the pivotal trial for Botox. It looks pretty similar, doesn't it? So within the first week, the placebo group gets better, the Botox group gets better, the Botox group continues to get better, so does the placebo group, but the Botox group beats them out at the end. So they have kind of similar curves when you look at large groups of people in studies. What about topiramate? So topiramate is used a lot for chronic migraine. It was studied in chronic migraine. Just to look at how many people responded in topiramate, if you compare this to modern day drugs, it looks pretty similar. At least half the people got better about half the time. They had some people that were 100% responders. But what the graph doesn't tell you is the people who dropped out of the trials. And in the topiramate trials, about 40% of the participants dropped out because of side effects. So just to kind of give you the highlights here, the monoclonal antibodies, they're all given by injection at the maximum dose. Some people really respond very well. Some people are super responders. They have a 75 to 100% reduction in their migraine days, maybe 10% of people at best. Generally low side effects. You don't have to worry about liver or kidney disease. Any kind of migraine is fine. The downside is insurance. And so sometimes these are hard to get. We have to fight the fight with the insurance company. They require that you try treatments in advance, that didn't work for you. So, there's a hassle factor here. The oral preventative, you do have to increase the dose. You need at least 2 months of an adequate dose to assess whether it's working. There can be side effects. There can be problems with other medical conditions. Taking a medicine every day is hard. The only thing that's harder is taking medicine 2 or 3 times a day. None of them are specifically approved for chronic migraine, although we use them. Yep. Sorry? You want to shut up? And that's the oral drug. The good news is they're all covered. And then there's Botox. It's given every 3 months, 31 little injections for chronic migraine only. Again, you have to have sort of step through a few other treatments to get it covered by insurance. And it takes 2 or 3 treatments to assess whether it's going to be effective. Moving on to the small molecules for prevention, atogepant is sort of the cousin of Ubrelvy, and it was submitted to the FDA for daily use for preventive treatment. Rimegepant or Nurtec is also just finished clinical trials and is hopefully going to also be approved for prevention. And then Visegepant, the one we talked about before, is also being studied for prevention, and they're looking into other formulations as well. What's on the horizon? PACAP. It is another peptide. It's very similar to CGRP. It's part of the migraine process. It's elevated in people who have migraine. If you inject it, just like CGRP, into the bloodstream of people with migraine, if they develop a headache. People that don't have migraine, they don't get a headache. Both a monoclonal antibody that targets the molecule as well as one that targets the receptor are both being studied in trials. We also have neuromodulation devices. You may be familiar with some of them. The bad news is that they don't tend to be covered by insurance, so they're hard to get. For many people, we have the gamma-cord device, which targets the vagus nerve in the neck, which has been FDA cleared for migraine acute treatment, as well as episodic cluster acute treatment and cluster prevention. The Cephaly device, which has been sort of reinvented a few times, and now is cleared for both prevention and acute treatment of migraine. The remote non-painful electrical stimulator that's worn on the arm, controlled by your cell phone. It's called the Nerivio device. Currently, it is approved for acute migraine treatment. They just did a trial for prevention, but it hasn't been cleared yet for that purpose. And then transcranial magnetic stimulation, the Spring TMS device, which is cleared for the treatment of both acute and prevention of migraine. Lastly, some old dogs and some new tricks. They keep bringing these back and trying to make them better, and there's nothing wrong with that. So non-oral formulations. Americans like to take pills. It's been shown in studies. They don't like to use injections. They definitely do not like to use suppositories. The French, however, like to use suppositories. That's also been shown in a study. I didn't make it up. But sometimes it really helps to have a non-oral option. If your migraines escalate and peak really quickly, like within 20 minutes, you probably can't take a pill that's going to be absorbed fast enough to work. If the migraine is maximal intensity at onset, so if they're present on awakening and the horse has already left the barn and this thing is raging out of control, if it wakes you up from sleep and it's already out of control, if the migraines are associated with nausea and vomiting, you're just going to vomit the medicine back up again. Or we know that sometimes oral triptans don't work well because the stomach is kind of lazy during migraine. It's not pushing things through to the other end like it's supposed to. In fact, it's working in reverse sometimes, which is why people get nauseated. So there are new formulations of sumatriptan. Some of these are not super new, but the 3 milligram injection in Zembrace, the 22 milligram nasal powder on Zetra, it is still available. Somebody told me it was taken off the market. It's not, it's still available. And then the newest one is a reformulated nasal spray. And if anybody's ever used the old sumatriptan nasal spray, you know that this stuff is the nastiest tasting thing on the face of the planet. You kind of can't help swallowing it. So it's not getting absorbed in the nose. it's being swallowed, so that decreases the effective dose, and also you taste it. And then the nasal spray that just came out has been reformulated so that it really gets to the back of the nasal cavity and it gets absorbed there, and so it works faster. In clinical trials, there's transdermal zolmitriptan. We actually did this trial at UT Southwestern, and are going to do it for cluster. We did it for migraine. So there's this little micro needle patch that delivers Zomig under the skin or into the skin. And we'll be hearing the results of that soon. I don't know them, and I couldn't share them if I did. Oral Celebrex, DHE nasal spray, and there is a nasal spray already, but I think this one's going to have advantages over the old one. DHE nasal powder, an oral combination of meloxicam and rizatriptan, which is Mobic and Maxalt, with a new technology. So the rizatriptan will hit fast, and then the meloxicam will kind of pick up, hopefully, and extend the duration of relief. And then also a combo with sumatriptan or Imitrex and promethazine, antiemetic. So I've been wondering how long it would take for someone to make that combo. And then there's a new botulinum toxin that's also in clinical trials that hopefully will last longer than Botox, which tends to wear off at 10 weeks. So this is really an exciting time. I've been doing headache medicine for a long time, and we haven't seen excitement like this since the early 90s when sumatriptan came on the market, and maybe when Botox got FDA approved for migraine. But there's just a lot of stuff going on, a lot of people doing research in migraine. So I think it's an incredibly hopeful time. We now have preventives that are specifically designed for migraine treatment, acute treatments that can be used in patients who don't tolerate triptans or who can't take triptans. I think we'll still, nothing's perfect, and we'll still have to use multiple therapies in a lot of people. But, the new options are, in general, better tolerated than some of our older medications. And that may improve adherence, especially since some of them only have to be given once a month or once every 3 months. The GPANTs, now the CGRP medicines are now available for acute treatment, preventives to follow. And I think other headache conditions are the next thing we're going to hear about once the drug comes on the market. Then studies can be done for menstrual migraine, cluster headache, adolescents and children. And so I think the scope of all of this is just going to expand. So I do want to thank you. I did walk this morning before I got on, and I always wear my Miles for Migraine hat when I walk. And I thank you all for your support, and I thank you for your attention.
That's excellent. Thank you so much for your time. What an excellent presentation. You give us hope for sure. So if you don't mind, we have a few questions for you, and if everybody doesn't mind hanging on for a few minutes, we would love to ask you some questions.
I would love to answer them.
Okay. Let's see. Can you take Rayvow if you're taking ketamine nasal spray? Can you combine those two?
As far as I know, you
Okay.
can. It's never been studied. This is just my personal hypothetical answer. Both of those things can be sedating potentially. So I certainly wouldn't plan to do anything the first time you try that experiment, but I don't really know of a scientific reason why you couldn't.
Oh, you can't.
And that kind of brings up the whole thought of combining other things, right? Like, can you combine a CGRP oral with a triptan? No reason that you shouldn't be able to. Again, never been studied. Or with a ditan, or with anything else, right?
Okay, perfect. Perfect. Thank you. Why do you find so many have not been offered a preventative?
I think that many, even I hate to say it, neurologists, but certainly primary care physicians, it's just not really on their radar screen. They tend to offer acute treatments, sometimes acute treatments that I would not be my first choice, let's just put it that way. I think that, triptans have been out for a while, and most primary care docs are familiar with them, and they're comfortable at least with one or two of them. And then, on the preventive side, amitriptyline's been out for a while, propranolol's been out for a while, topiramate has been out for a while. But it takes a long time to really get a good headache history. And a lot of times in primary care, doctors and other providers don't have that much time. They're being forced to kind of crank through patients and take 10 or 15 minutes and they're done. And it doesn't give the patient really an adequate time to express how often they're getting headaches and really the effect that the headaches are having on their lives. So, my advice is, you can spread it to your friends if it doesn't apply to you. When you go to see your primary doctor or your primary provider, if you want to talk about headache, talk about it first. Don't wait until you're walking out the door. Go with a list of questions, go with your stats and say, this is what I want to focus on today, and ask about preventives. Because there have been a lot of population studies done on this. It's not just my impression. Preventives are markedly underutilized in migraine treatment.
Thank you. I agree. Always have your little book with your questions. Don't think you're going to remember something, right?
You'll get distracted, I guarantee you.
I agree with you. So you had brought up a new drug, Vyepti. We haven't heard a lot about it. How is it doing on the market, and what can you tell us? I just have heard one story that someone had gone and it took 30 minutes for the Vyepti and they left. Can you tell us a little bit about how it's going with this new drug that's out there?
My experience is kind of limited because unfortunately for Vyepti, they got marketed them in the middle of a worldwide pandemic, right? So there hasn't been as big a shout about Vyepti as with, I think, the other ones. But it is given intravenously. You have to go to an infusion center. The infusion takes exactly 30 minutes, right? So they start an IV, they run the stuff in, and you leave. And it's good for 3 months. I can tell you that in the clinical trials, it was very well tolerated. The most common side effect in the clinical trials was kind of allergic, a hypersensitivity reaction. And it wasn't common, but that was, it was probably maybe 5%. I think it was less. But it did well in clinical trials, and they actually kind of looked at their data and they went back. So they started at the 3-month primary outcome and they started backing it up to day 1 to see how early it would work compared to how many people would have been expected to have a migraine on that day based on their run-in diary data before they started the treatment. And they actually came up with the conclusion that it can start working on day 1 for some people. So I think that the jury's still not in as far as what we're seeing in clinical practice, just because it came out just, 4 or 5 months ago, maybe? And you don't really know until at least 3 months after the patient has taken it, whether it's working or not. But I'm hopeful that it will be. They also studied it in emergency room setting because it can start working so fast. So see if anything comes of that. You could get acute treatment and preventive treatment, one-stop shopping in the emergency department.
Oh, wow.
That would be interesting.
Yeah, that's actually really exciting because the emergency room is really where we, I'm sure as you know.
That's where you don't want to go.
Oh, that's where you don't want to go, but that's where us as migraine patients really get the look as though, you only have a headache and here's some Tylenol, go home, or are you seeking drugs? But if that's something that's actually there for us in the ER, that is really awesome news for us, I think.
Yeah. So we're not there yet, but that's what they're hoping for.
Well, that's great.
Trying to figure out the whole prior approval thing. You can't get prior approval when someone's in the emergency room, right?
Wow.
So they're kind of working around that one.
Wow, that's exciting. We have a few more questions for you, but I just want to say, in case some people drop off, because I know we're over, if you don't mind a few more questions, I just want to remind everyone that you will, after the day is over, if you will receive a survey, and we would love if you don't mind filling out the survey for us, because that's how we learn how we're doing. And so I just wanted to remind everyone of that if people start to drop off because they have other things going on in their day. We appreciate you joining us, but we are going to ask a few more questions. if you don't mind answering them. Your presentation
Alright.
is just awesome. So, is there any evidence that these repants are effective for vestibular symptoms?
They didn't, I don't know if that was ever looked at in the clinical trials. Now you could be in the clinical trials and get vestibular symptoms, obviously.
Right.
Like it didn't preclude the enrollment in the clinical trial. But I'm not sure if anybody has actually looked at that, or even if people in the clinical trials documented that. That's a good question. Usually when they do the studies, they look at, your pain level, your pain relief, over time. You have this diary and you have to keep entering stuff like every half an hour or so till your headache goes away. And they also look at the most bothersome symptom, but dizziness is not considered a most bothersome symptom by the FDA. So it's not something they would track.
Okay.
If anybody has experience, I would love to hear what has happened. If the dizziness is part of the migraine, it should get better.
True. Okay, interesting. All right, thank you. And is it common for the body to begin to adapt to preventatives so that they no longer are effective over time and require a change?
That happens very frequently. It's called tolerance. And it can happen with acute treatments as well. People come and say, I used to take sumatriptan, it worked great, and now it doesn't do anything for me. And that can happen with preventive. So to some extent, we could increase the dose on some of them, but then often, you get into side effects, and so that doesn't work. That is a very common experience.
Okay, unfortunately, right? Like my Botox works great, but over time, maybe it might not work for me, or.
Yeah, and it may be inconsistent. For Botox in particular, that some months it may, or some cycles it may work better than other cycles. It's hard to know if that's really the Botox or if that's other things going on in life or seasons of the year or something else.
Okay.
But a lot of people notice it's not consistent.
Okay. Yeah, mine sometimes I feel like it lasts longer in some, sometimes, and it's shorter other quarters. I noticed that. Okay, let's see. Do you have any suggestions on how to get your neurologist on board with neuromodulation devices? Both my neurologist and headache specialist do not support it.
Your headache specialist doesn't? I hope you're not coming here. In fact, I know you're not coming here because we love neuromodulation devices.
I know where they're not going. Another place they're not going either.
Anyway, I don't know why they wouldn't be on board. You do need a prescription for them, right? So I find it kind of hard to believe that if you brought the stuff in and said, would you please prescribe this for me, that they wouldn't prescribe. That's no skin off their back. But I don't know.
Call Dr. Friedman.
Why they would not be on board. I think they're safe. I mean, that's the best part. They're not pharmacologic, unless you have, like a pacemaker or another device implanted in you. They're very safe. They can be used during pregnancy. That's not official, but there's no risk. I think they're great options. They haven't caught on really well, and I think that's just because they're not covered well by insurance.
Oh, that's true.
Fight the fight.
Yeah, that's true. Okay, how about one more question for you? How different is Imitrex from Rayvow? Anything work if you don't catch it at the exact first signs?
Well, how is it different? It's totally different. They're totally different. They attack totally different receptors. They work on different receptors.
Okay.
I think it is true, and they just actually showed this with Ubrelvy. They analyzed data from people who took it early in the long-term follow-up study where it was open label and everybody had the real drug. And they found that it really did make a huge difference when people took it early. So I think it's fair to say that with any of these medications, taking them earlier is usually the better strategy.
Yeah, I agree with you. If you can get it when it's started instead of waiting. And sometimes people wait for some of them because you have, some of those you have 10 a month.
Right.
That's how they try to space them out and say, oh, let me wait on this one and see. And then you get too far into it. Yeah.
Yeah.
Well, you have been, go ahead.
Oh, I was about to say, you know, with some medications, you worry about medication overuse. And so that's why, that may be one of the reasons why that they limit the quantity you can get in a month.
Yeah.
A lot of this is just historical. It goes back to the original Imitrex trials. And it's just been carried forward, not to get, you know, more than 9 to 12 or whatever for triptans. But we don't know yet for sure, but it is looking like the newer medications do not have a high risk of medication overuse, which makes sense because they're using them for prevention, right? Taking them every day. So, you know, hopefully that'll loosen up, and it'll be interesting to see if they get approved for prevention, you know, and people are able to get a whole month's supply for their preventive treatment, you know, what happens after that, and what happens to people who just want to use it acutely. So I don't know.
Very true. Well, we love your hat, and you gave us such great information. What an awesome presentation. And so we are unfortunately at the end of our day, and we want to thank all of our amazing presenters as well as our sponsors. And please don't forget about our virtual run, walk, and relax events, our virtual support groups, and our mindfulness events that are going on through the month. We want to thank you all again, and thank you all for joining us. It was a great day. Thanks. Have a good rest of your day.
Thank you all.
Yep. Thank you. Bye.
Thank you. Thank you.
Thank you very much.
I'll take care. Be safe. Take it off. Zoom. There we go.